Can you just give us some background about your experience as an OT and how you found yourself working in this area?
Sure. So I actually just stumbled across it really randomly. After I passed my boards, I was just applying for jobs in Las Vegas, and one of the ones that I had seen was for the organization that I currently work for. And it was part-time initially, but the job description had something about fall prevention, which was something I dabbled in a lot in my master's program. And so I felt confident in that. And that was also the hospice that my mom was at the end of her life. So, I just, figured I'd also apply for the job. It would be nice to work for an organization that worked with my family at the end of life. They are a really good organization in the Las Vegas community. So I figured if I had a part-time job and then do a per diem job, that was my direction initially. But, I just came in and they had told me, this is the first time we're ever hiring an occupational therapist. I had my supervisor at the time, she wanted to she came back from a conference. And so she wanted to add the OT in because as many years and decades she had been in healthcare, she was just really beginning to understand what OTs and PTs can actually do and how it applies to hospice, specifically for fall prevention. And so she wanted to kind of add this position to make their care more quality, to say that, this is something that we really value too, because a lot of these patients, they are declining, and even just one fall can further compromise their quality of life. And so it initially started out as that. And, I was kind of excited by it too, even as a new grad, because it's, you start from scratch. And, I operate in that way. I think I get nervous when, you walk into a culture and there's already these set sorts of practices. And sometimes they're not the most healthiest ones, but kind of taking that ownership and setting that standard was exciting for me, as much work as I knew it would be, but it became full-time rather quickly, and I'm here now. So
That's awesome. Have you had any other certifications, trainings, or CEUs in hospice, or are there any that you hope to complete?
So I know that hospice has certifications for nursing and recently social work. And so our organization, they're great in a way that they encourage that among the disciplines that work there, but specifically for occupational therapy, there is not an official one. I hope to see that in the future, but I love learning. I love just taking classes. I guess one that I took earlier this year before COVID was a trauma sensitive yoga certification. And so that one was a really, really cool certification workshop I did for the weekend. It was a lot of the things that I was already kind of teaching to. So a lot of breathing, the use of language, and even just very gentle stretches or exercises for relaxation that, you would find your patients value or benefiting from. So it was a great workshop overall. And these families, these patients, they're experiencing their own sort of trauma too, or even anticipated trauma. So I apply a lot of those things there.
That's awesome. Have you had do you use any theoretical models or frames of reference when you have your area of practice? And how do those kind of shape your interventions?
It's with occupational therapy, and I say this to everyone all the time, but it's really everything that we're taught in the program, holistic. And those are things with hospice too that they value: holistic, person-centered, caregiver-centered. And I'm sure there are a lot of models and frames of references that I use, but it just matches so well with occupational therapy. You're really looking at the person, what their environment is like, because you're already in the home. What were their occupations in the present, even in the recent past. And you just really get to know them in that way, and it just aligns with the philosophy really nicely. So
What are some of the diagnoses that you commonly work with? And are there any that are maybe more particularly challenging than others?
sure. The great thing with hospice too is that you see everything. And my two field works, one was in acute rehab, and then the other one was at MD Anderson in Houston. So that's a cancer hospital, and I got to work on the palliative care floor as well as the multiple myeloma floor. So that was really, really helpful for me being exposed to cancer. So that's probably the main one that I get a lot, but you get everything. You get dementia, Alzheimer's, Parkinson's, COPD, you get stroke. And that's the great variety that you get, even as a new grad coming in there, all of those things are still fresh in your mind. And, it makes it more interesting too, because you get to see the different stages that they're in. So all sorts of things at different stages.
So are the clients that you're usually seeing, are they typically receptive to getting occupational therapy, or do you ever get refusals? How do you manage those situations?
Surprisingly, and that is the reason why I think I'm just so passionate about it. And, going in, I wasn't really sure what my role would be, but, more often than not, I get comments from families, oh, I didn't know that this was available to us. And if anything, it's quite the opposite. So, I generally try and see my patients once a week, 2 to 3 times a month, in case, there's a week where I might have new referrals, and, that time needs to be given to somebody else. But, if I had it my way in a perfect world, I'd see them all the time. And, it's sad, but it's also very, very, I guess, I don't know what the right word is, but it makes me also happy too that, oh, you're not coming back until 2 weeks. What? Because the thing is that they're deprived of their occupations, and their existence a lot of the time beforehand just came down to the very simple things. And so you're coming in there, you're kind of that breath of fresh air that, you're not talking about medicine, you're not talking about pain, you're just talking about living life and how they can do it. And I think it's really well received, and, it's easier to listen to somebody else than your own family members also. But yeah, they're actually really, really receptive. And if I get refusals, and that's expected, just on any given day, I'll call maybe 30 minutes beforehand, and, yes, come over. And then in that 30 minutes, all of a sudden they just get really tired. That's okay. Fortunately, I'm not bounded by a lot of things that you would find in different settings where, so for instance, I don't have to spend X amount of time or see a certain amount of patients through my organization, but more often than not, you can redirect anything to the caregivers because they have a lot of needs as well.
Just to clarify, are you completing home visits typically, or what setting are you seeing the patients in?
So most of the patients that I'm seeing are in home. Okay. So I'm doing home hospice. There's 3 levels of hospice, but the main one where a lot of patients are seen are in the home.
Okay, thank you. Mm-hmm. And what's your level of collaboration with the other therapy disciplines? So like speech therapy or physical therapy, are those also provided?
No, so I am their only OT, and I think beforehand they were, and I think how a lot of hospices are generally operating is, because PT, OT, speech services, that is a benefit on hospice, provided that it is appropriate. And so families can ask, and it is the duty of all hospices, whether it's profit or nonprofit or for-profit, to provide that. My role, I guess, is unique because I'm employed full-time with them, but the collaboration not really existent, but they would, but other hospices, or if somebody needed speech therapy, they would contract from another agency and go from there.
Okay, that makes sense. And could you describe the process of gathering an occupational profile in this
Sure.
setting? So, with the caregivers and also if the individual doesn't have family members around and they're not able to communicate very well, how do you obtain that info?
Sure. So, you know, there are no OT formal assessments for hospice or palliative care, but I struggled with that at the beginning, but it was also very quick for me to get all of that information, because you have to consider, you know, they're in a sensitive part of their life, but also time is of the essence. And, you know, the way that I structure a lot of my visits, you know, you want to build that rapport, so it has to be sort of conversational too. I explain my role, and then I actually kind of give the floor to them by asking, you know, okay, walk me through what a regular day is like for you. And you can find a lot of answers there and get the information that you need, whether or not they are very responsive initially, or, you know, sometimes they tell me, I don't know, I get up and this is my existence. And then you just learn to kind of unpack the sentences and the things that, you know, they're saying, and you just break it down, and then you find that they actually are doing a lot in their day, and you can kind of guide your intervention from there.
Okay, thank you.
Uh-huh.
And what assessments are you typically using? You said there's not any formal assessments, so is it typically questions that you form beforehand, or?
So after walking me through what a regular day is like for you, if there are any assessments that I do use or incorporate, it's a fall assessment that my hospice as a whole uses. So it's the Missouri Alliance for Home Care, so the MAC-10, but that one is rather general. So, I mean, there's maybe 10 items on there, and if a person scores a 4 or more, they're considered a fall risk, which is 99% of the hospice patients. So.
Okay. Do you ever do any reassessments with them using that assessment, or?
It's really more of a guidance or a screening for me. I think,
Okay.
you know, that is definitely an opportunity in the OT profession, to kind of be in hospice and formulate an assessment that is more specific and will really tailor to the needs, because, you know, there's more often than not, when I see patients, there's something that just gets missed, and it's not to the fault of anyone. It's just, you know, we're just programmed to see these things, and, you know, this prevents a fall.
Mm-hmm. How do you go about finding evidence-based interventions to use with clients, given that there's little research regarding OT's role in hospice?
Sure. You know, it's been interesting, but also very helpful for me, because I'm doing my post-professional doctorate through UNLV right now. So in tandem with working, I'm also, you know, having to do all of these research assignments and finding something to do for my capstone. So the literature that's available, although that, you know, it's not specifically hospice, a lot of the fall stuff or the home health stuff really does apply. You know, the only really difference is some are on hospice and some are not. There's a lot of characteristics that are similar that, you know, can very well be applied and be added or considered for something like program development. So, you know, I use a lot of evidence-based fall prevention interventions, and just meaningful activity. You know, all of that stuff is in research and evidence-based, and, you know, it's been very easy almost, and surprisingly easy as an entry-level person going into this field.
What are some of the evidence-based fall prevention interventions? Do you look at like environmental modifications, or what are some examples of those?
Yeah, great question. So recently, well, it was actually a couple of days ago, I'm really trying to I guess, structure the approaches and methods within our organization, because it is very big and it's really hard when, you know, COVID's happening, there's nurses coming in and out, and on top of that, it's home health. So, you know, people are kind of put on board on training and then they're out in the wolves. But, you know, something that I am working on is just that structure. And so I presented to my supervisor and 3 main articles that I had used to support it, and one was very recent, and I think it was highlighted within our profession, but it was with the American Journal of Preventive Medicine, saying that of the 7 interventions and the 7 fall risks or fall risk factors assessed, home modification by an OT and then vitamin D supplementation, I guess, were the most effective. And so that was me kind of really advocating and supporting for, you know, this is a process that needs to happen. We really need to specifically tailor it to, you know, home assessment, home safety, and make that a focus, because we're seeing patients in the home. Strength and balance, mobility stuff is also very often something that is a large part of my visits, because before they see OT, many of them are very, very inactive. And, you know, it seems kind of counterintuitive because, you know, these people are on hospice, but, you know, when you think about it, and I tell this to my patients all the time, you know, if you're just laying in bed when you can move, when the time comes for a transfer, you either fall again or it's just a bad experience and it's this negative feedback loop. That causes more falls, that may cause fear of falling, which is another risk factor for falls. And so really taking the home and taking their strength and balance, mobility, DME, all of that stuff, it kind of really meshes well together so that they're adapting to their environments as their body goes through these different changes.
Do you ever experience difficulty engaging the patients who are nearing end of life in participating in things that you suggest?
Surprisingly, no. I mean, of course, if there is a day where they're just not having it, you know, my attention shifts more to the mental health aspect. But again, they are wanting to do it, which, you know, makes me just, you know, if there's anything about hospice that makes me sad, it's not, you know, that they're dying. I rarely ever even think about that. It's more so, okay, I had a wonderful visit with this person and we were able to do A, B, and C. How many other people right now have these same opportunities but don't know that it is, sort of thing? And yeah, so they're always wanting to.
How do you navigate difficult conversations with your clients, such as death, if these are brought up?
I don't really know how to answer that question. And I think, you know, once you're just kind of thrown in there, you just know. And I mean, I've experienced death before. And so I think maybe that helps me just, you know, what I heard. So I've lost my mom and my sister within a span of 6 months as a teenager. And so I kind of like to put myself in their shoes as to things that maybe I heard as a teenager that just weren't very helpful, and then try to avoid that. And, you know, I think OTs naturally just have that therapeutic use of self, and you really harness that in the hospice setting. Sometimes silence is the most appropriate thing, or just even I think something that I've really developed working in hospice is unpacking what they're saying. So they might say something that, you know, seems very cold, or just something very, you know, oh, they don't want to be around me. But if you just really read between the lines and take that time to listen, you know, a lot of the times you don't even have to offer any sort of comfort, because that's not what they need. They just need somebody to listen and, you know, be patient with them.
Right, that makes sense. So how do you address the psychosocial components in your practice, such as like if your client's experiencing episodes of anger, anxiety, or depression?
I mean, the therapeutic use of self, again, unpacking those questions, listening to them. And, you know, sometimes too, it's, say I have, and this is something that I see often in hospice, is they're illustrated as being non-compliant or very difficult to work with, and then when I come in there, it's just, we're best friends by the end of the visit. And there's always something that's kind of rooted in that. And so if somebody, say, is illustrated as bedbound, doesn't want to get up, is in, say, a lot of pain, you go in there and then you find out that, well, maybe it's pain, or it may be an actual fear of falling, or maybe they're just tired. And so you have to address that in hospice above all before you can get them to do anything. And, again, it's to the fault of no one else, but I think we are really unique in a sense where we understand that. And so we would address that before having to do A, B, and C, because once you get to the root of that and you build that rapport, it's so easy for them to do anything. They're so receptive.
Okay. You explained that you don't experience a lot of grief when working with patients in hospice. Are there any strategies that you use to avoid bringing these feelings home with you, or
Sure.
any negative feelings?
Great question. And, it's something that I've thought about very recently, and I'm close to 3 years in hospice now. And, for the most part, I think that I did a good job of handling it. I think because I am so passionate about the field, it was easy for me to disconnect. And I think a lot of that also has to do with my experiences in the past. But in the times of COVID, I would especially find myself a lot more emotional. It was harder for me to separate it, and I would often, bring whatever stresses in my day, and then, it would escalate or amplify within whatever patients that I saw that day. But it's really that self-care. And there's philosophies I think that I've just developed in my 20s and even just grad school, where, you just have to bring yourself to the place of, one moment at a time, just as I preach to my own patients, that mindfulness aspect, just, knowing too, and perhaps it sounds kind of morbid, but knowing too that, you're in that role where you're making the last moments of their life all the more better. And that's what ultimately helps me. But at the same time, it's, all of us will eventually die as well, and I think a lot of them have come to grips with that. And, I think it just helps develop you as a person. And I think just being in the field, you find that balance of being compassionate and looking at that big picture and knowing you're making a difference, but you can't be attached to it. So that non-attachment and, a lot of principles of, I guess you would say, yoga and mindfulness really get me through.
Yeah, that's good. Do you ever experience difficulties interacting with caregivers at all?
Difficulties, well, they're okay to navigate, but there are times or certain scenarios where it can be hard, and it could be a scenario where the caregiver perhaps has a lot of hope or really optimistic, and then the patient isn't. But that can also certainly be roles reversed, where the patient is very, very optimistic and the caregiver not so much. So sometimes frequently I navigate scenarios like that, or sometimes I just have uninvolved caregivers, or it's hard to implement any sort of care plan, because if it's a spouse of a hospice patient, they're often elderly too, and they're just going through a lot. So you have to have that compassion above all, and know that it has nothing to do with you or what your efforts are, or and just you do the best that you can. The one thing that I will say though, and I think this might be an element to one of the other questions that you guys had asked. So if a patient doesn't have caregivers, or there's really no one there to kind of help them out, and you see that too. A lot of people are living alone, or perhaps passing away alone. The great thing about hospice is that, they're full, well, at least for my organization too, but I would say the same for other ones, is that, they don't like the idea of people dying alone. And so, you think about or reflect on cultures that you guys have had field work in, or places where you've shadowed. And in hospice, it really is, even though we're home care, there is kind of that solidarity and that compassion and really interdisciplinary way of functioning. So if a person's alone, it's the staff that helps them and advocates for them. And there's a lot. There's CNAs that they're seeing, there's nursing, OT, social work, spiritual support. And, while that's not the perfect scenario, at least you really have that involvement with them.
Going back to the caregiver question, can you give an example of a time you experienced a challenge when working with a patient's family and how you resolved it?
Sure. So I guess I'll use that example that I had given, but I had a patient that would sometimes, he was on and off in his cognition. He could certainly express his needs if you gave him that chance and if you caught him at the right time. But there were times where, it was just obviously not what he wanted. But the caregiver too, would just kind of be a little bit pushy, kind of telling him things, hey, you need to listen to her so that we can do A, B, and C. And the people are stubborn sometimes. And, it's just, hey, it's being firm and being assertive, which, it's also required, I think, with that compassion. And it's just telling them, hey, obviously he is not wanting to do this and I don't want to force him to do it. And, you always kind of have to stress to the caregivers or even the patients, we're looking at the one day at a time. Tomorrow it's going to be different. Tomorrow you may not even feel like getting out of bed. This point, and some get that, but some you just have to be more direct, where it's just, okay, well, this is not appropriate right now, and or you can't keep pushing him if he's obviously in pain, or and it's you just have to tell them my goal isn't to get you independent. Sometimes you just have to say that my goal isn't for you to just be able to walk, fly again. My goal is for you to get out of bed right here, right now. Not to say that it's off the table, but this is what we need to practice. And you just provide that rationale, really, and they're pretty receptive to it.
So what is the most rewarding aspect of your job?
That's a good question. And, honestly, I guess the best way that I can describe it is that it just makes me a better person. We have all of these ideals and the type of person that I want to be. And, hospice really brings that out in me. So, if I want to be, for instance, I want to be more confident or public speaking or, being more assertive, really. And, when I'm in hospice, I'm in my element. And so, having to get to know people really fast, and building that rapport, those are skills that are important in everyday life. Patience too. I could certainly use patience in other arenas of my life, and hospice is what helps me develop that skill. So, ironically, it is, the end of life, the death, the dying stage is what actually teaches me how to live and be a better person, and just good reminders of it.
As future OTs, is there anything else you would like us to take away about this area of practice?
I just, it's always so surprising to me. I don't think that it's so much of people's lack of interest in it. You know, there's so many people within the OT and PT field that want to work in this setting. It's just really more so the structure and systems in place, and just even the overall perception of how death is, that speaks to the very limited presence of the therapy field. It is probably, you know, I mean, I've worked in the acute rehab setting, and I don't really have much experience besides that because hospice was the first job that I took. But one, hospice is not anything to be afraid of. And that's what's been so surprising. It is actually, you know, even during the times of COVID, when I was working in the first couple of weeks, when I was able to start seeing patients again, that was what energized me. You know, it's a really positive, quality of life focused approach, and you know, it shakes down those just general perceptions. You know, just advocate for it, I guess, or just even go into assisted living facilities, or just even hospice organizations, and you know, explain the role and you know, sell yourself, I guess. That's a question that I get a lot, and you know, I just tell them how my role started. You know, if you want to sell, you know, a role to somebody, you know, of course, quality of life above all is the most important. But when it comes down to it, the people that are stakeholders, the people that are in charge, that doesn't ultimately matter. They need evidence-based. They need something that is cost effective, and so tailor it to fall prevention, because that's something that's always important with everything and everyone. And, you know, that, and then everything else kind of translates into our philosophy. So, you know, the quality of life thing, and you're doing a lot more than the fall prevention, obviously, but, you know, for people to care. And I mean, that's kind of my pursuits now in going to school is, you know, directing the lens towards that, so then the other people can see what it is that we're actually doing. Because the concept of doing, that's essentially what's adding to their quality of life and preventing the falls. But because it is sort of this unexplored territory, it has to make sense for them. We know, but it has to make sense for others, for more people to entertain the idea of bringing more OTs, because it's literally, hospice philosophy is very much similar to OT philosophy, if anything. So yeah.
Thank you so much for taking the time to meet with us. We really appreciate it.
Thank you guys.
That was really informative, and you had great advice.
Oh no, thank you so much for talking with me.
Thanks
I
so
appreciate
much.
you guys.
Yeah,
Let me know if you guys need anything.
Thank
Okay,
you.
thank you
We
so
look
much.
forward to following you on your Instagram page as well.
Oh, wonderful. Please follow, share with your friends.
Sounds good.